Shamsher Singh. It was a wonderful presentation and very insightful. So now we will address the questions from the audience which we have received. So I will read out the question, ma'am, and Dr. Chauhan sir.
I can go ahead with the questions. Yes.
Yeah. So, ma'am, first question is asked by Dr. Smriti Modi from Kolkata. She wants to know how a physician can differentiate PDS and EPS clinically.
See, EPS is epigastric pain syndrome. So patient will have upper GI epigastric pain or epigastric burning. Postprandial distress syndrome, the term is self-explanatory. It occurs after a meal. Patient mainly complains of bloating. Patient complains of belching and abdominal discomfort. So it's a combination of symptoms in postprandial distress syndrome and early satiety. Patient eats a bit and is full.
Next question, Dr. Praveen Dhani has asked from Indore. Most of the patients in our practice want sudden relief from functional dyspepsia. How to start prokinetics and which is the best preference?
So, yes, ma'am.
You go ahead, yeah.
Okay. So, in such a set of patients, see, the word patient may not always signify that the patient is sick. It means you need to have patience with the illness. So we can always have a conversation with the patient that yes, drugs are important. They are needed. You need to adhere to them. And over a period of few days, things will improve. So you can start with either drug that we've been listed in as a prokinetic, either domperidone or acoshamide or etopride or cindepride, depending upon your choice of practice. You can, if there is bloating, which is predominant, prokinetic can be upfront used. If there is more of pain, then only a double dose PPI may be helpful. And you can always probably at times, if the pain is predominant, you can add an oxytocin based syrup so that the pain kind of gets better and the patients have symptom relief.
Now, I would like to add here, because you have certain commercial kits which have domperidone and a PPI, and that domperidone and such kits are only in India. So we don't like to give these combinations, because inadvertently, patient, if he takes it twice, that goes to 60 milligrams of domperidone, and patient can have side effects. As Dr. Shamsher has earlier said, 30 milligram domperidone, there are no side effects. And if patient has bloating as a main symptom, acoshamide is a good drug which can be given for postprandial distress syndrome. And mainly, diet has to be, what I would like to stress is, one should have healthy dietary habits. If the patient has these symptoms, limit your fat content, limit your fiber, don't have too bulky a diet, limit your food intake, have small frequent meals. If patient is symptomatic, give low food, because very often dyspepsia with irritable bowel syndrome, you have a combination of symptoms. So you have to give low FODMAP diet.
Ma'am, the next question is how should be escalation and de-escalation of prokinetic and PPI if both have been started?
As I told you, we always give drugs separately. Initially, if a patient has epigastric pain and burning, then you give twice a dose, twice a day PPI. And if the patient has a lot of bloating, then obviously you have to add a prokinetic drug. If bloating is the main symptom, add a prokinetic drug and then a PPI. So PPI is also, I will say, is the most abused drug. PPIs, you should limit it to 4 weeks, 6 weeks, maximum 8 weeks. And then what we say is treatment on demand. Treatment of demand is you can give a PPI for 8 days, then you stop the PPI. Long-term PPI, we know what the side effects of long-term PPI. It can give rise to C. difficile diarrhea. It can make a patient susceptible to GI infections. It can cause interstitial nephritis. So PPI give for 6 weeks, 8 weeks max. Proton pump prokinetic drugs, Prokinetic drugs we give to 6 weeks, 8 weeks, because we don't have long-term data. But usually we give for 6 to 8 weeks, then we give a stop period, and then again treatment on demand. If the patient is bloating as a main symptom, prokinetic. If the patient's symptoms are persistent, patient is more than 45 years, at least it warrants an upper GI scopy and an ultrasound.
Thanks,
Dr.
Dr.
Shamsher would like to add anything, Shamsher?
No, ma'am. Correct, actually. And of course, looking at red flags also, if the patient is upfront having any red flags, cancer history in the family, gastric cancer, they also would warrant an upper GI endoscopy at the
Correct.
outset. And we can, it's not a usual practice, there's no data for it, but we can always at times taper the PPIs. Like you give it twice, then you give it once, then probably alternately, and then on demand. So that may also kind of the symptom wise get much relief.
So as ma'am and Dr. Chauhan said, it's a nationwide CME program. Has been broadcasted everywhere. So we have received quite a lot questions from the audience. So I'm selecting them. And also I will ask the audience to please share your questions from your clinical practice that you face as the challenges. Okay, this has been asked by Dr. Sanjay Jain. In a patient without red flags, when do you choose empiric treatment versus upper endoscopy?
If the patient is a young patient has no alarm symptoms, patient is young, you can start empirical treatment. Any patient more than 45 years, very persistent symptoms, you have given a trial of medications, patient is not okay, investigate.
Ma'am, Dr. Jitendra Yadav is asking, though, I mean, combination we have already answered, but if still the combination is given, like acosamide with any other prokinetic, how long do this combination should be taken?
We don't combine prokinetics. Prokinetics is either acosamide, it depends on which prokinetic you're offering the patient. So what was the question you said? If you're giving
so he's asking basically same acosamide and prokinetic combination. But I think you have rightly answered that such combinations actually is not recommended.
Not recommended. Combination of prokinetics is not recommended.
Correct.
You can see if the patient is not better with the PPI or prokinetic, then you can add neuromodulator drugs. Now, neuromodulator drugs are selective serotonin reuptake inhibitors, or you have selective serotonin, noradrenaline reuptake inhibitors. So you have SSRIs and SSNRIs. So initially we start a neuromodulator, we can give amitriptyline. Amitriptyline also has a latent period, as I've said, 2 to 3 weeks before the patient really symptomatically is better. It's a safe drug. Or you can, if the patient not better with amitriptyline, then you can give SSRIs or SSNRIs.
As madam has already said that we can always wait for about 4 weeks before going up. The side effect, we would always look at the patient at the outset. If the patient is more anxious on presentation, a small SSRI may be helpful at the outset, explaining that, nowadays people chat GPT. Google has been long gone. They chat GPT and they come to you and then they'll know that you're probably treating them for depression, but you are probably giving them a drug that is for neuromodulation. Now, as I always tell to the patients that these drugs that we give, like amitriptyline or SSRIs, they are at a dose which may not affect or treat depression, but they will always help in neuromodulation of the neurons in the stomach. So as neuromodulation helps, the pain gets better. So if the patient is upfront having symptoms of anxiety, they're more anxious than their GI symptoms, upfront may be helpful. Otherwise, yes, a trial on the trot will be beneficial.
Would you like to tell them the side effects of SSRIs and SSNRIs, Shamsher?
Sure. Yes, ma'am. So whenever you start a neuromodulatory drug, there are few things that we are looking at. Of course, there is sedation, there is somewhat nausea, SSRIs can cause diarrhea, and TCAs, that is amitriptyline, and sometimes even SNRIs, they can cause bad constipation. In elderly, because of the anticholinergic side effects of TCAs, they can cause, especially in elderly males with prostate problems, they can cause urinary retention. You need to ask for glaucoma if you're starting with TCA, so that the intraocular pressure does not rise with TCA. So all of this done. Another important side effect that you need to tell these patients is probably they can have a low libido. Males can have low erectile dysfunction, and this is reversible. But then, it just adds to the anxiety of the patient if it happens. So you got to tell them upfront that we're going to start you on this. There is some chance that this can occur. If it occurs, please notify us so then we can change our therapy. But don't get disheartened because it's a reversible thing. So these are the common side effects that you need to upfront tell the patient and list them down when you're writing them on your prescription, that this is common side effects. It'll help you from a medical legal point of view as well.
Thank you, Dr. Chauhan. Dr. Rakesh Mohan is asking how long etopride should be given, and that brings to me to have more elaborate answer from the acoshamide perspective. Then if acoshamide is started, then when the symptoms relief is observed, and once symptom relief is observed, then how long it has to be continued.
So
Shamsher can take, yes,
Yes,
go
ma'am.
ahead.
So acoshamide, when it starts, it takes about 3 to 4 days for complete effect to come. And because of the drug that builds up and the synaptic left, it takes about 3 to 4 days for the effect to come. So you can always tell the patient that at the end of 1 week of starting this drug, you should start feeling much better than what you are today. To continue with, yes, there is long-term data for 1 year, but as practicing gastroenterologists, we might only give it for probably 2 to 3 weeks at the outset. See how the response is. If the patient is symptom-free, maybe extend it for 2 to 3 weeks more, and then slowly stop it or withdraw it and then give it on demand. Again, if the symptoms recur, you can give it for 2 to 3 weeks and things like that. So even that goes for any prokinetic, etopride, cinetopride, or even acoshamide. So all of them can be given for 2 to 3 weeks and then restarted if the symptoms recur. But if they recur, they need investigation. They need an investigation in the form of an upper GI endoscopy if not done. They require evaluation for thyroid, for hypercalcemia also, all of which can cause low gastric emptying. If their sugars are uncontrolled, that requires a correction. All of this said and done, if the psychological part of the patient is not looked at, that also requires therapy.
Now about etopride, now patient who has esophageal reflux symptoms and has a high volume reflux. If it's a high volume reflux, etopride can be given because it's said to, there are increased levels of what is called as transient lower esophageal sphincter relaxation in these patients. So it decreases the transient lower esophageal sphincter relaxation. So a patient with volume reflux, etopride can be given. Acoshamide is for postprandial distress syndrome mainly.
Ma'am, next question has been asked by Dr. Joshi from Dehradun. This is about as we have already elaborated all the tests with the diagnostic test, but this question is about the water drinking test. So what is your opinion about water drinking test for assessing functional dyspepsia, and how much should be the volume? Or do you recommend any test, ma'am, for to the physicians? Actually, they can do and assess.
See, we have enumerated these tests, but in practice, most of these tests, let me be frank, are not done. Basic, we do an ultrasound of the abdomen, and in certain cases, especially if we're suspecting gastroparesis, we do scintigraphy. Because scintigraphy is reliable both for solid liquids, but there's some degree of radiation exposure, and you use a gamma camera for imaging. And all these other tests like wireless capsule or water test All these usually are not done in practice. Even MRI is not done for diagnosing of your functional dyspepsia evaluation. And if the patient has persistent symptoms, you are given trial of medication for 4 weeks, please upper GI scopy is the minimum one has to do, sonograph and upper GI, and if required, biopsies.
So if I rightly understood, ma'am, if patient coming to the physician with the symptoms suggestive of functional dyspepsia, he can initiate the treatment, say acoshamide, and then after 4 weeks, if the symptoms still persist, then he may refer the patient to gastroenterologist.
What happens when the patient comes to gastro, already taken enough PPI, is taken enough prokinetics. So then
Right.
we have to, what happens? Patient is already taken for 4 weeks. Then we really investigate them because we don't want to miss out on any symptom in the patient.
Right. So Dr. Chauhan, what would you like to suggest physicians if the patient coming first time to them with suggestive symptoms of functional
So,
dyspepsia?
of course, the patient, if they're coming to them for the first time, we will always look at the age criteria, as Madam has said, 45 and above. We will always investigate, look at the hemoglobin, look at thyroid, calcium, sugars. These are bare minimum blood tests that you can do. Look at the creatinine, that also can impair gastric emptying. If these things are normal and there are no red flags, you can probably directly start them on therapy on day one. So your prescription on day one will include these blood tests and a set of prokinetics with PPI, depending upon what symptom is more common. If it's more of bloating, you can add prokinetic with PPI. If it's more of for pain, only PPI with probably oxytocin based syrups. If they don't respond in 2 to 3 weeks, then of course they will need evaluation, as Madam has said, endoscopy. Even if that is clean, then we know with a common intent that yes, this is not anything sinister and this can be required with certain other drug modification or maybe neuromodulation.
Thank you, Dr. Chauhan and Dr. Sawant, ma'am. Now, in the interest of time, we will take up the last question from Dr. Deepak Sharma from Agra. He wants to know about the use of immediate release and extended release of aquaciamide.
So, the extended release is, I think, 300 milligrams OD. As I said, none of the drugs or prokinetics should be given as an extended release formulation because you want the drug to be in the synaptic cleft or along the receptors just before the meal so that the gastric accommodation gets better. If it's continuously there, the receptors will develop tachyphylaxis, and what effect it shows on probably a day or two, then it might not show on the subsequent few days, and patient will have a loss of response to the drug. It's not the problem of the drug, it's probably a problem of the physiology behind treating such a disease. So it will always be immediate release, 15 to 20 minutes before meals, along with the PPI. And I think that's how you would always look at treating. Of course, it increases the pill burden, but trust me, as gastroenterologists, patients are compliant, specifically patients with functional dyspepsia. They would always be compliant to therapy. The first thing that comes to mind is, yeah, okay, there's a combination. One pill a day, the patient will always take, maintain compliance. But it may not in the long run have much benefit. And when I say long run, could be just within a week also. But patients of functional dyspepsia are very compliant. We've seen that in our practice. They are compliant to therapy, and because they are suffering, so they know after eating they will always get this bloating. So they know to have to take this drug just before meals. So that is what I think I would say, that any prokinetic aquaciamide also before meals only, not as an extended release tablet.
Thanks, Dr. Chauhan. So any concluding remarks from both of you?
Yeah, so I think we have elaborated and we have gone through the pharmacokinetic pharmacology of drugs which are used in functional dyspepsia. So functional dyspepsia is quite common in our day-to-day practice. Functional dyspepsia, very often we say with overlap of irritable bowel syndrome. So rule out diabetes, rule out hypothyroidism, do a basic ultrasound, rule out chronic pancreatitis, see whether the patient is lactose intolerant, and then you can give the patient, is it epigastric pain syndrome, distress syndrome, or is it a postprandial distress syndrome or epigastric pain syndrome? Give the drugs accordingly, whichever we have discussed. Thank you for a patient listening.